Hello, this is Dr. Praveen Chandra from Medanta, the Medicity, Gurgaon. And along with me is Dr. Abhinav, who is a very experienced now interventional cardiologist. So we are working together in this young patient who came to us with acute coronary syndrome in January of this year. And that time, can we have the initial pictures? I'll just show you the pictures from that time. She had triple vessel disease, and RCA was the culprit at that time. So I'll just show you. Yeah. Okay. So show the initial pictures. I'm just going to show you. This is the angiogram which we are doing today. And this is the LED which we are going to treat today. But earlier we have treated the right coronary artery, put a stent there, and we have put the circumflex stent also at the same time in January. And then we staged this procedure to left coronary treatment for the later time. So January first procedure, and now we are doing it in April, the second procedure. So can you show the previous? Yes, now we can see that. So this is the first angiogram. You can see LAD is significant, but not so critical at that time. Circumflex is tight, and the RCA was the most critical lesion at that time. So we treated this. Next, please. And here you can see that it was difficult to put the wire at that time. And then we did find some difficulties, but IVUS was used to assess the size, and then we used a 3.5 millimeter stent and we had to go to high pressures because it was a fibrotic lesion. There was not much calcium to be seen, but certainly calcium, fibrosis was there. But we got a very good result on this right coronary artery. Okay. And here you can see that the lesion has progressed in the last 2 months. Next, please. LAD has become much more significant, and that is why she was having so much symptoms. So I'll show you the IVUS runs. Show the IVUS, please. And on IVUS, we found that this vessel is about distally about 2.75 to 3. There is some plaque in the actual distal segment in the mid distal part, but not significant enough. But in the mid and the proximal part, the plaque burden is quite high. It is non-calcific, heterogeneous, and of course, you can see that the size of the vessel is there's some, again, little bit of fibrotic elements here, but going up to the ostium, the disease goes up to the ostium. The distal left main has some minor plaques, but nothing much. However, in case we have to stent this artery, we have to stent it from the left main to the LAD. And so that is why our strategy today is to see if we can avoid stenting and do it with a Wolverine. Wolverine, this strategy is one of the good strategies in young patients where we can avoid. Yeah, and now also to tell you, as Dr. Abhinav said, that we have put the FFR wire to keep tracking our intervention. And in case we find that everything is okay, and you can see that the FFR values are 0.68 to start with. We did the dilatation with a, next please, with a 2 millimeter balloon. And with a 2 millimeter balloon, we did receive some increase in RFR coming up to 0.74. But now we are going ahead with a cutting balloon, which is Wolverine. And it's a 3 millimeter into 15 Wolverine. So here we are. And I'm using a very, 3 into 15. Can you check again? So the dilatation is getting to a good level. 9. Okay. And now I'll do some more dilatation here. Go up, please. Okay. Good. Very good. So no residual at 10 atmospheres. Deflate. So now I'll bring to the ostium. She's having some discomfort, which is expected. Check, please. So this is with the 12 atmospheres, 3 into 15 Wolverine. And she has some chest pain, nothing to worry. The pressures are good. Everything looks good. Deflate. Okay. So the flow is good. And on FFR also, we are not getting good, residual flows. So it is still 0.69, which means this, flap is a little occlusive, and we'll have to really stent it. Okay. Now we'll start with left main because the plaque is there in the left main. So if we have to end in the left main, we'll have to cover almost up to the Austin. So this is the LAD, which is now looking much better, but certainly we need to improve. And let's see what happens on this evaluation with the OCT. So you can see the OCT run now. Show me the. So this is the dissection. You can see in this picture, it's quite actually, a big dissection, deep dissection. So we'll have to stent it. So we'll check the length of the lesion and also everything. I mean, it looks like 44 if we cover the proximal lesion only. So we'll take a 44 first. Okay. Now, so we are taking the stent, which is a 344. 344. So this is the middle sizing of the cruise, which goes up to 4.25. So whenever we are landing a stent from the left main into the LAD, we have to really be careful about the limits, expansion limits of the stent. This is a good sizing, I think. Okay, check now. Yeah, I think it's okay. Check again a little bit. Yeah, it's okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8. Yes, 9. Okay, so we are inflating up to 9 atmospheres. Deflate, please. You will feel some chest pain again, Kanchan. Yeah, it'll be okay. Give me a 3.5 balloon. Pain will go away slowly. So this looks nice. The flow is good. All the branches are flowing nicely. And the circ is also flowing nicely. 3.5, please. 3.5. So I will do a 3.5 post dilatation from the proximal to the ostial segment, and then we will do a OCT. Okay. The lumen looks good, and here you can see that this 3.5 is in position. We will do a stent boost. Can we do a stent boost, please? Yes. Okay. Connected? Okay. Yeah. So it is getting better gradually. Okay, fine. So it is still, we need to do some work on this because I need to have at least above 0.9. Okay. So we'll do a OCT run. So the distal stent is very well expanded, and you can see the OCT now. And the middle part also looks good. Let's go to the proximal part. We can do some work here with a 4 or something. How much is the size now here? There are some struts which need to be expanded proximally, about 4. So give me a 4. 410. Okay. So all the branches are flowing nicely, and show me the lumen size at various levels. What is the minimum size there in the middle part? Do we need to dilate with the 3? No, distal, more distal, more distal. Beyond the here. 6.48 is good. Yes. And the distal edge is absolutely fine. Yeah, I think it's good. It's good. It's good. It's good. Yeah, this is very good. So the OCT is quite satisfactory. Okay, it's okay. Yeah, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Okay, so we have done with the 4. Deflate. It should be fine, I think. Okay. At the moment, we are fine. And here we are with the 3 millimeter balloon. 3 millimeter into 12. 312. Please check. Deflate. Okay. Okay. So we are here with the 3 millimeter balloon. So I will start from the distal part and go proximally. Okay. Go up, please. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. Deflate. 14, 16, 16, 18. Okay. Deflate. So we are optimizing the MLA little bit more. Go up 18, 20, 20. Deflate. Abhi theek ho jayega. Deflate. Looks good. So all the arteries are fine. The flows into the diagonal and the septals are fine. And I think that's good. So what about the ostium? What did we see in the ostium of the LAD on OCT? Although we dilated with the 3.5. The flow is much better now. The distal LAD is flowing so well. It's much better compared to the. Show the first one, the first shot. First shot, please. Next one, next one. So this is the first one. You see, it's like little slowish. And now show the last one. Dry gauze, dry gauze. Okay, show me the FFR now. So the RFR is now how much? 0.88. Now it has come to 0.88. So what I can do is I can pull back a little bit and see if the middle lesion also needs to be treated or not. So come to the FFR, please. The present FFR, how much it is? Okay, it's about 0.9, 0.88, 0.9. We started with 0.68. And this is 0.91 now, which is okay. I mean, I would have preferred 0.9. So can we do the FFR now? Let's do the FFR. Because now the question is what to do for that middle lesion, distal lesion, which is an isolated small lesion. We can treat it, we can leave it, we'll see. What is this? Okay. So go to the FFR mode. Yeah. Okay. Are you ready? So what is the FFR? Baseline FFR is now 0.94, which is good. Most likely it will turn out to be negative, hopefully, but I will give now. So I have given adenosine. Okay. Yeah. And, so finally, I will have a quick look again with because there is some, residual which I see at the ostium of the LAD, which I might have to reconsider doing with a 3.5 high pressure. But let me see. Okay. I mean, this place is also nice. I think we are done. So we are absolutely done. And the MLA at the ostium is how much? MLA at the ostium. It's like about 8.5 area is good. So I think we are happy to leave it now. We can take a final shot in the RO caudal. Let's have a 8 French angioceal. So here we are, and okay, so let's check. I think we are fine now, absolutely fine, and nothing to be done. We can leave it here, wire out, and very good result. So I'll just take this out and give me a wire, please. So, basically the idea was to get the best outcome in this kind of a diffuse disease, and without compromising the side branches, without, trying to do too much, and checking the anatomy and the physiology, both imaging and physiology is helpful in this kind of a complex situation. So I will take a shoot of the femoral artery to see if we can close it. Go up, go up, go up more, 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 up, up, up. Yeah, table up. Yeah, that's fine, that's fine. Okay. Yeah, yeah. Okay. So I'm going to take a. So we are just at the bifurcation, I think. We are just at the bifurcation actually, because the bifurcation is very high. You can see. I'm still not very sure. Go back. Give me some more contrast. LAO. I can check in the LAO also. Just pure contrast. It's okay. Go down. Go down. No, I think we are above, just above the bifurcation. So it's okay to angioseal it. Okay. So it is very important to check whether you are in the common femoral, or, and sometimes it is difficult to check. And so from these three angles, we can make sure that everything is okay. Give me this thing, betadine and angioseal 7/8 French. Now it'll go away. It'll go away slowly. Your artery is fully open now, and we got a very good result. Okay. You will be okay. Your artery is flowing very nicely. Show me. Okay. Okay. Oh yeah. Give it. 7, 8F, 8F. So now we are going to angioseal it, and probably if everything is okay, we can discharge her tomorrow. Yeah. So I think we are done. Thank you very much for this case, and we can have some discussions a little later.